morning and good afternoon to everybody. Thanks to the panelists of this ESID Grand Round. And let me say something at the beginning, very few words. When ESID asked us to organize a Grand Round on antibiotic prophylaxis, could you hear me?
Yes, Isabella.
Okay. When ESID asked me to organize this Grand Round on antibiotic prophylaxis, I had many doubts. Since the paper published in the literature are very few, the practice of antibiotic prophylaxis is really heterogeneous, and it differ a lot between what I know in the United States and the European countries. From what I know, is more widely used in USA than in Europe, and for sure may anticipate just now that we will not reach any conclusion after listening all the speakers and after the discussion. But our aim is to open new studies, new collaborative studies, in order to have better data to discuss all together. This is a very crucial point, and let me start by showing the program of today. And so we decide, together with Silvia Sanchez Ramon, who's co-chairing this symposium with me, to start with a small introduction on antibiotic prophylaxis in primary antibody deficiency, and this will be done by Cinzia Milito of my group. Then, since the problem of antibiotic resistance is so crucial in this topic, we ask Maria Monaco from our NIH, the Italian NIH, to give a presentation on the state of art on antibiotic resistance in Europe. The Italian NIH is part of the collaborative study in Europe on antibiotic resistance, and she will show us some data on the actual situation of the antibiotic resistance in different microbiological strains. Then I asked Alexandra Freeman to talk on benefits of antibiotic and fungal prophylaxis. Then I read a very interesting paper from David, and so the title, his title is Antibiotic Prophylaxis, or we should also think on microbiome. And then I will ask Silvia Sanchez to make the conclusion and to start the discussion together. Sorry, could you switch off the microphone? There is someone who is talking. So this is the program of today, and I leave the few words to Silvia Sanchez Ramon, and then we will start. Please, Silvia.
Thank you very much, Isabella. So we have a truly exciting and important topic to discuss today. And before we get started, a couple of housekeeping notes. This session will be recorded, and I encourage everyone to participate actively. Please feel free to submit your questions through the webinar via the chat box, as Eleanor has already written. And this is a wonderful opportunity to engage with these expert panelists, and we look forward to a very interactive discussion. So that said, now it's my pleasure to introduce the first speakers. Professor Isabella Quinti, full professor in internal medicine and clinical immunology and head of the Primary Immunodeficiency unit at the Sapienza University of Rome in Italy, and Dr. Cinzia Milito, which is a clinical researcher at the Primary Immunodeficiency unit at the Sapienza University of Rome, that will begin discussing antibiotic prophylaxis in primary antibody deficiencies. The floor is yours, Isabella and Cinzia.
Okay. Lacking protective antibodies, common variable immune deficiency and X-linked agammaglobulinemia patient experience acute respiratory infection that can be reduced by IgG replacement therapy and antibiotics. But despite IgG treatment, a subgroup of patients develop chronic lung disease as the result of a vicious circle, infection, inflammation, leading over time to tissue damage and remodeling. This subgroup of patients may take advantage of a more aggressive therapeutic strategy, including antibiotic prophylaxis and respiratory rehabilitation. Macrolides were proven to be effective in the management of chronic infection-related lung disease as cystic fibrosis, bronchiectasis, COPD, and asthma, as reported in this previous published paper. Conversely, data about antibiotic prophylaxis in inborn errors of immunity were heterogeneous, not supported by guidelines, based on single institution specific experience or personal feelings, and limited by the idea of by the risk of bacterial resistance. Based on these observations, we designed a phase 2 randomized double-arm multi-center study to evaluate the efficacy and safety of low dose of azithromycin as long-term prophylaxis to prevent respiratory exacerbation in primary antibody deficiency patients. We designed a 3 years prospective study with equal randomization and involving 7 Italian immunological units. According to the study design, we enrolled adult patients with a diagnosis of XLA or CBID and associated respiratory chronic condition. Patients received azithromycin 250 mg a day or placebo for 2 consecutive days a week for 2 years, following by a period of 6 months of run out. We chose a low dose of azithromycin to improve adherence and reduce adverse events. But how may azithromycin prophylaxis be useful to prevent respiratory exacerbation and lung damage in primary antibody deficiency? Azithromycin has antimicrobial effect, but also anti-inflammatory and immunomodulatory properties on neutrophils, eosinophils, and lymphocytes. In this way, azithromycin can contribute to have a positive effect on vicious circle infection inflammation, leading over time to airway hyperreactivity and remodeling. These one are the results from our study that until now is the only randomized paper published on this topic. In particular, our primary outcome was achieved. We observe a reduction of respiratory exacerbation rates over time in patients receiving azithromycin. Also, secondary outcomes were reached. In particular, we have a lower rate of hospital admission in the azithromycin group, together with a lower annual courses of antibiotics in patients receiving azithromycin. In addition, we reported decreased counts of white blood cells and neutrophils in the azithromycin arm during the whole study time. And conversely, we did not report any significant change in lung function. Regarding microbiological analysis, we collected a total of 304 sputum samples from patients receiving both azithromycin and placebo. The most common bacteria detected were Haemophilus influenzae, Klebsiella pneumoniae, Streptococcus pneumoniae, and Pseudomonas aeruginosa. Streptococcus pneumoniae and Haemophilus influenzae isolate, not susceptible to macrolides, accounted for 86% and 79% in the azithromycin and placebo groups respectively. The risk of having a Streptococcus pneumoniae and or Haemophilus influenzae strains resistant to macrolides was similar in the two study arms. To conclude, in primary antibody deficiency patients with the chronic infection-related lung disease, the long-term prophylaxis with low dose of azithromycin reduced the rate of respiratory exacerbation, the additional courses of antibiotics, and the rate of hospital admission. Azithromycin was safe in terms of side effect and adverse events, and contributed to decrease white blood cells and neutrophils count during the entire study time. The efficacy of azithromycin prophylaxis in our study was comparable with the efficacy reported in previous study on COPD, cystic fibrosis, bronchiectasis, and asthma. The total efficacy on reducing respiratory exacerbation could be empowered by the immunomodulatory effect of this drug on the vicious circle infection-inflammation. For this reason, when prescribing azithromycin prophylaxis, we have to consider the balance between the risk of driving a bacterial resistance and the possible benefit on the overall bacterial resistance due to the reduction of additional courses of antibiotics. Thank you.
No. We go now to the antibiotic resistance.
Okay,
I just asked Cinzia to summarize our data. Since our study, as she said, is the only double-blind randomized study against placebo, so this is the reason why, not because we are proud of ourselves, but this is the only study we have in our hands at the moment for a randomized one.
Thank you very much.
I think that Monica now.
Okay, so we go through our next speaker, which is Dr. Maria Monaco. Is a senior researcher, microbiologist at the Istituto Superiore di Sanità, Department of Infectious Diseases at the University of Rome. And she specializes in clinical pathology, and she will address antibiotic resistance in Europe. Maria.
Thank you, Silvia. My name is Monica, not Maria.
I'm sorry. I'm sorry. No.
A small mistake. Yes, thank you for the introduction and for this kind invitation to this webinar. Let me share the screen. Okay, I start. Thank you for inviting me to this very interesting webinar to talk about one of the major public health issues at the global level nowadays, that is antimicrobial resistance. In particular, I will focus on antimicrobial resistance in EU. As you know, antimicrobial resistance is one of the top global health threats. Sorry. And it annually causes a high number of deaths, and it is estimated that bacterial AMR was directly responsible for more than 1 million global deaths in 2019 and contributed to almost 5 million deaths, as reported in a paper published in Lancet in 2022. We all know that the main AMR drivers are the misuse and the overuse of antimicrobials in humans, animals, and plants that are a sector very close interconnected, and AMR affects countries in all regions at all income levels. Its drivers and consequences are exacerbated by poverty and inequality. AMR puts many of the gains of modern medicine at risk, and it makes infection harder to treat and makes other medical procedures and treatment much riskier. In Europe, AMR is monitored through the European Antimicrobial Resistance Surveillance ERSNet, that is the largest publicly funded system for AMR surveillance in Europe, and it plays an important role in analyzing temporal and spatial trends of AMR in Europe. The data originate from national AMR surveillance system, 29 EU EEA countries, and only data from invasive isolates of 8 bacterial species, as shown below among gram-negative and gram-positive, are included in the ERN surveillance. Later on, I briefly show you a couple of examples of resistant trends for Streptococcus pneumonia and Staphylococcus aureus. In addition, AMR data are annually published on the European Antibiotic Awareness Day, coordinated by the ECDC, during the World AMR Awareness Week, coordinated by the WHO. Data are also available for public access through the ECDC Surveillance Atlas of Infectious Disease web tool. This tool allows users to interact and to search for data to produce a variety of table and maps that you can see in this slide, showing the resistance percentages of in this slide of the main pathogen antibiotic or class of antibiotics combinations. The resistance percentages are indicated, as you can see, in the right side of the slide by a gradient color. And these pathogen antimicrobial agent combination are those that are relevant for from a clinical and epidemiological point of view. The red scale you can see in these maps indicates the highest resistance percentage that are mainly reported in the southern and eastern European country for some of these combinations. As mentioned before, now we focus briefly on Streptococcus pneumonia. That is the most common etiological agent for bacterial respiratory infection in the community, especially among children, elderly, and immunocompromised patients, causing severe diseases as pneumonia, meningitis, and sepsis. And in Europe, as you can see in the table below, over the last 5 years, and increasing and significantly increasing trend in the mean percentage of macrolide and penicillin wild type resistance was observed. While considering another pathogen under surveillance, Staphylococcus aureus, and resistant to methicillin. Resistant to methicillin is the main resistance marker for this pathogen, and it is under surveillance. We can observe that in Europe, during the period 2018 to 2022, a significantly decreasing trend was observed for the MRSA percentage. ERN surveillance contributes also to the global antimicrobial resistance and use surveillance system. The acronym is GLASS, and this is the global surveillance coordinated by the WHO, which includes not only laboratory data, but also epidemiological, clinical, and population level data, and include not only invasive infection, but also infection from other body sites, such as samples from urinary tract infection or genital infections, or stool also infection samples. And it enjoys close collaboration with other AMR regional networks, such as the Central Asian and the European Surveillance of Antimicrobial Resistance, CESAR, the Latin American Network for resistant surveillance, and the Western Pacific Regional Antimicrobial Consumption Surveillance System. To conclude, I would like to show you, to share data from the last annual epidemiological report on antimicrobial consumption in Europe. The ESAC net surveillance provides us data on antimicrobial consumption. ESACnet is a wide European network providing European reference data on antimicrobial consumption, both in the community and in the hospital sector. And the good news is that the European mean total consumption of antibacterials for the community and hospital sector combined had a statistically significant decrease over the last 10-year period from 2013 to 2022. And this value, 2.5% reduction, was observed since the baseline of 2019 toward the EU target reduction on 20% by 2030, as stated in the new EU recommendation that would step up the action to combat AMR in Europe. So to conclude, a robust surveillance system to monitor AMR trends is in place in Europe. There are strong differences among countries, with AMR levels being generally higher in Southern and Eastern European countries. And the good news is that antibiotic consumption has decreased in European countries in the past 10 years. And thank you for your attention.
Next, the next speaker is Dr. Alexandra Freeman, who is a pediatric infectious diseases physician at the National Institute of Allergy and Infectious Diseases, who focuses on the diagnosis and management of primary immune deficiencies, who will talk about the benefits of antibiotic and antifungal prophylaxis. Alexandra.
Thank you. Thank you so much for the organizers for having me speak today. And can everyone hear me okay and see the slides okay? All is good?
It's perfect, yeah.
Okay, perfect. Thank you again. And I do feel like that the title was given to me about antimicrobial prophylaxis, and starting out hearing about how the United States is, probably not doing as well with restricting antibiotics. So I did try to throw in a few non-antibiotic or non-antimicrobial approaches to minimize infections as well, to be a good infectious disease doctor. So, I thought I would start by bringing up that, as Dr. Quinty had just mentioned, there is a huge lack of placebo-controlled prospective trials to really help us approach this big question of what type of prophylaxis we should give. The two studies that I know about are in CGD and itraconazole, as well as the one that we just heard about from the group in Rome for the primary antibody deficiencies with chronic lung disease and azithromycin. And I'll mention both again as well. And I do think there's a lot of variations between centers. I think that has been highlighted recently, for instance, with the use of JAK inhibitors for the STAT1 and STAT3 gain of function, that Europe is using more acyclovir than us, for instance. And that, a lot of the practice is driven by experience from other diseases, such as HIV, expert opinions, but also, anxiety. And then we really do have these increasing concerns of resistance. So I thought I would just highlight the two placebo-controlled studies. And, I won't talk much about Dr. Quinty's group, just because that was so nicely just explained. But to talk about the first one was in 2003, which was looking at fungal prophylaxis and chronic granulomatous disease. So this was a placebo crossover study in which the patients either received itraconazole or placebo, and then they crossed over to get the opposite, so each year of what they were receiving. And, this study really nicely showed that, that itraconazole prevented the, the really significant aspergillus infections that we can see in CGD. I have the table there on the right showing the individuals in the placebo arm, when they were, again, it was crossover, when they were receiving placebos, and they had 7 fungal mold infections compared to the patient who had the 1 infection while on itraconazole. And there was a note saying the patient had not been adherent with itraconazole, which, we all know that happens, right? We all have patients that are not perfectly adherent. And just a couple other comments from this. This was using itraconazole, which isn't always absorbed all that well. Itraconazole capsules are not absorbed as well as the liquid. And, this wasn't on huge doses, but it really nicely showed that it did prevent these mold infections. Since that period of time, we have, many more triazoles available. We have posaconazole, voriconazole, isobuconazole. Our group, and I still think it's proper if the patient doesn't have a disseminated fungal infection to start with itraconazole, but the other ones are there as well. Posaconazole, this is just a couple things to remember. Liquid is dosed differently than the pills, and the pills with posaconazole are much better absorbed than the liquid, which is actually the opposite of what we see in itraconazole. And voriconazole really does have long-term concerns, so I don't think it's a great option for prophylaxis because it has concerns of photosensitivity with skin cancers and fluoride, increased fluoride levels. And I wrote down some of the doses that are used there for itraconazole, with the main adverse issue event being both the liver, and it is a good idea to at least check the liver function test right after you start and, once or twice a year, as well as medication interactions with the azoles that we do see, including with steroids, that the patients can see higher doses of steroids because the metabolism is impaired. Again, I'm not going to go through this study because this was so nicely just discussed, but I felt very amiss not even including a slide about it because this was just such an important study when the group came out with this from Italy, and just because we really didn't have any of the placebo-controlled studies, and so I think just to highlight a couple things that were already discussed, but that we did see less exacerbations, less hospitalizations. So that means less of the other antibiotics that were being given. For instance, for Pseudomonas, that means less of things like the extended cephalosporins or meropenem or piptazo. And that azithromycin is so unique because it has non-resistance qualities. It has those anti-inflammatory qualities. But also, if you become resistant to azithromycin, it doesn't have cross-resistance with some of the others, like cephalosporins or the beta-lactams. There is the concern of QTc prolongation, and many of our patients end up on multiple medicines. So, I do check an EKG, and I know that was one of the questions that had come up. I do it. I think it's kind of a low, it's easy to do and has big implications. But, and I also thought I would mention that I also worry some about, in the patients with bronchiectasis, that you can have infection or colonization with non-tuberculous mycobacteria, like Mycobacteria avium complex. So I do get Mycobacteria sputum cultures before I start azithromycin in that setting. Okay, so, so that's kind of the prospective placebo-controlled studies. But, we do have some retrospective data. For instance, in chronic granuloma disease, the main antibiotic that's used for prophylaxis is trimethoprim sulfa. I put the dosing there. And retrospectively, this was without the use of interferon gamma, which I think is typically in Europe, interferon gamma is not used as much as the US. But it does reduce serious infections from about, 1 bad infection, a bacterial infection a year to about 1 every 4 years. It is a really, really great antibiotic for the non-fungal infecting organisms because the sulfa has activity against Nocardia, Staph aureus, Burkholderia, Serratia, which are, the main 4 bacteria that you see in this disease. The other thing that is really kind of important in CGD is that you're getting infections from the environment. These aren't usually chronic infections. It's not that you're colonized with Nocardia and then you have it. You're getting it from Nocardia in the soil where you're not going to see as much trouble with resistance. And then the sulfas don't have cross resistance. If you become resistant to sulfa, it doesn't make you resistant, for instance, to beta-lactams. These days, a lot of the patients are going to transplant, but, until transplant, I think this is really indicated, and not every patient is transplanted with CGD. I think there's a huge question of what do we do if the patient is sulfa allergic? And here's a circumstance where you really want to make sure they really are allergic because the other choices are not as good. People have used trimethoprim alone. We often use a 2nd generation cephalosporin like cefuroxime. And I just have pictures here for Nocardia pneumonia and a staph lymphadenitis. So I just wanted to contrast CGD a little bit with, the disease I see the most of, which is hyper IgE syndromes, and with STAT3 specifically, dominant negative hyper IgE syndrome, because here again, we use a lot of trimethoprim sulfa, and those very similarly to we do in CGD. And this is really to prevent the staph pneumonias and the skin abscesses and eczema that we see. But compared to CGD, in these patients, they are often chronically infected with staph. You see it on their skin, you see it in their nose, the respiratory tract. So you do have many more troubles here with resistance. So here, to help kind of counter that some, I do like to use antiseptics that can really decrease the amount of staph on the skin. So either through bathing in dilute bleach baths or with chlorhexidine washes, the hope is that will decrease the amount of staph resistance. And, increasingly in the United States, and I think in some parts of Europe, dupilumab is used for the eczema in these patients, which has not only showed improvement in the eczema, but by healing that skin barrier, we're seeing a lot less staph infections as well. Just looking at the cohorts, again, we don't have prospective data in this disease, but about 90% in the large French cohort that was published back in 2012 were on prophylactic antibiotics, mostly trimethoprim sulfa. And they did see, when that was combined with immune globulin replacement therapy, that the infections did decrease by about 2/3. And in our cohort of patients with this disease, about 95% of them are in prophylaxis, largely with trimethoprim sulfa. We do sometimes use doxycycline if the staph is resistant, or beta-lactam. And we do often add azithromycin, which I'll talk more about, if there's chronic lung disease such as bronchiectasis. And we do suggest using antifungals if there is a lot of trouble with chronic mucocutaneous candidiasis, or if they have pneumatoceles. And you can see here in this patient's chest CT with the large pneumatoceles and the fungal balls inside of them, that's what we want to prevent. So in that circumstance, we would use itraconazole if there's not aspergillus inside there to prevent them from having a fungal ball. If they have a fungal ball, we typically use posaconazole. And you can see on top, those are the staph pneumonias that we're trying to prevent with our trimethoprim sulfa or some sort of prophylaxis. And then I thought I would highlight a paper that we recently published looking at early diagnosis in STAT3 hyper IgE syndrome, because this is somewhat showing the impact of antibiotics. These were babies born to in families where either the mother or father had the disease, and so they had a genetic diagnosis really early in infancy or even before they were born. And the antibiotics, which was trimethoprim sulfa largely, were initiated then in infancy. But they were initiated often with antiseptics. But, I do think in this study where we compared them to patients that were probans, where there was no family history, we did see a lot of improvements over time. And I put in red some of the significant changes that we saw, this kind of a large decrease in the number of skin abscesses that the patients had. In between the patients that had family history, where there was only one patient that had an abscess compared to the 9 of the probans without family history. The recurrent pneumonias, which was quite significantly decreased, as well as chronic lung infections, as well as hospitalizations. Now, we did see, one of our patients with a family history had a pneumatoceal. So this was not significant in terms of pneumatocysts and bronchiectasis. But I would say, I didn't put up here the chest CTs, but that patient has a teeny pneumatoceal, that has not had any infections related to it compared to the ones that did not have family history. But I think this suggests that, starting both the antibiotics with the antiseptics early in life really is impacting the natural history of this disease. Then I thought I would talk a little bit about bronchiectasis and a little bit of how I manage that, because for both hyper IgE syndrome, as well as a lot of the antibody defects, we end up with bronchiectasis. So, and here I thought I would highlight some of the non-antibiotic choices too. So first of all, in a study by Jordan Orange a bunch of years ago that I realized I didn't put down the reference, it did show that optimization of the IgG trough. So these are patients that have antibody deficiencies. This isn't hyper IgE syndrome, but there also the IgG replacement can help to improve the frequency of pneumonias, which hopefully will help with the worsening of bronchiectasis. But I do a lot with airway clearance, and I put up 2 chest CTs here where there's bronchiectasis. The one on top is actually a STAT3 patient, the one on the bottom is IL-6XT. But, I use a lot of kind of the airway clearance devices, hypertonic saline, either 3 or 7%, exercise, vests, anything to try to get that mucus out to decrease the exacerbations. I do often use azithromycin, just as was highlighted in Dr. Quinty's study. I think I use it more frequently daily, 250 milligrams daily. I think that's just the practice from my institution. I don't have any data to say that's better, but sometimes we use 3 days a week. But again, sometimes I'll use 500 milligrams instead of 250 because of cystic fibrosis literature. I just don't think we know what dose we're supposed to use there. Again, I rule out non-tuberculous mycobacteria. I frequently do an EKG. If I'm still dealing with trouble with Pseudomonas, I do sometimes use inhaled antibiotics with tobramycin, month on, month off. And then I do periodic sputum cultures to know the colonization. So that if a patient comes in with an exacerbation, I know which antibiotic might work best. And Pseudomonas antibiotic resistance is a huge concern. And then further prophylaxis, and again, we don't have time to go through all the diseases, but I kind of started with the one where I think we agree the most, which is severe combined immune deficiencies. I mean, I don't think there's any doubt that everyone gets pneumocystis prophylaxis, antifungal, typically fluconazole, considering an antiviral based on the mom's history and the baby's risks, all to be well for transplant. And then we think about pneumocystis prophylaxis for combined immune deficiencies. I think all of us probably do, early in life for CD40 ligand deficiency. I do for all my patients with DOCK8 deficiency and frequently Wiskott, when we're at least for the early childhood. And for instance, for things like DOCK8 and Wiskott when you're preparing them for transplant. The defects that are risk of disseminated mycobacteria, NEMO, the autosomal dominant interferon gamma receptor deficiencies, the IL-12 receptor beta-110 deficiencies. If they do not have disseminated mycobacteria, I do provide azithromycin prophylaxis. I dose that 250 daily or 5 mg per kilo daily. NEMO, I think, is a really important one here because if you end up with disseminated mycobacteria, there's more of a risk in transplant. In the really severe defects like the recessive interferon gamma receptor defect, they typically have disseminated mycobacteria, and I keep them on combination antibiotics until transplant. Antifungal prophylaxis for STAT1 gain of functions and others with mucocutaneous candidiasis. There's been a lot of azole resistance that is a really big issue for these patients, and then limited oral options. I do like to suppress their mucocutaneous candidiasis if I'm going to start a JAK inhibitor. I typically do keep them suppressed, but then on the JAK inhibitor, which often does treat the mucocutaneous candidiasis, I then often do stop the azole when I can. But, I do worry there's, this increased risk of these oral and esophageal cancers and STAT1 gain of function. Is that because of the chronic candida and inflammation? So I do think suppressing that inflammation, suppressing the candida through one of these methods is important. Less in Europe, but in the United States and in some regions of South America, we have coccidioides, which is a really bad fungus for the patients with STAT1 gain of function. So if anyone's here from those areas, they all should be on an azole to prevent that. JAK inhibitors and STAT1 or STAT3 gain of function. In the United States, we've often used acyclovir or valacyclovir for herpes or zoster prophylaxis. But, in the recent study that came out from Europe, looking at JAK inhibitors, mostly ruxolitinib, they typically were not used and it wasn't a big issue. So probably is being overused in the United States. Maybe we should be just checking our titers and using there or those with a history of that. And then antivirals for others with viral susceptibilities, like STAT2 deficiency, the TLR pathway. I don't think we have data. They're well tolerated, low risk. And then I am an infectious disease doctor, so I like mentioning vaccines, vaccination for the close contacts, of course, influenza, and probably SARS-CoV-2 vaccines for everyone, even when they have antibody deficiency for the T cell defect. If they have bronchiectasis and you can minimize some of the respiratory viruses, I think that helps in terms of minimizing the exacerbations. The role of the HPV vaccine for those patients with warts, I think, is unclear. As we're transplanting those patients more, I used to do it for DOCK8 deficiency, but now I try to get them to transplant as soon as I can. Sometimes we do for GATA2 deficiency. Obviously, if it's a significant T cell defect, you're not going to use varicella and MMR live viral vaccines. But if it's kind of one of these, like, on the fence, you're not sure if it's a mild T cell defect, considering the varicella vaccination before MMR vaccine. And obviously in the significant defects, if you know before they're vaccinated, you want to avoid the MMR vaccine. I have a picture on the top there of a child that we saw recently with type 2 deficiency with significant rubella granulomas. Obviously, to avoid the BCG vaccine until the newborn screen is back, ideally, if it is a country that has newborn screening for severe combined immune deficiencies, and in families where there's the family history of one of the Mendelian susceptibility to mycobacteria defects, or CGD, and the typhoid vaccine as well. You can see at the bottom, that's a patient I saw with an interferon gamma receptor deficiency with BCG abscesses in his brain that luckily we treated. And then just a quirk. For whatever reason, the polysaccharide pneumococcal vaccine, we've seen really awful reactions in the STAT3 patients. We just use protein conjugate vaccines. So ideally, looking into the future, as Dr. Quinty nicely stated at the beginning, we really do need more randomized controlled studies to see the impact of antimicrobial prophylaxis. For instance, should we be thinking about this in patients with XLA or CVID who don't have a history of lung disease? And XLA, where we do see sometimes things like the Mycoplasma helicobacter infections, that's probably overkill. But, I think some of these questions of when do we start prophylaxis, really need answering, as well as the dose of those prophylaxis. And then the role of prophylaxis with the different immune suppressants that we're using more and more, like JAK inhibitors. And then, of course, the impact of them on the microbiome and antibiotic resistance. And with that, I'm happy to answer questions at the end, and I put my email address as well for questions. Thank you very much again for allowing me to speak today.
Thank you very much, Alexandra. And finally, our last speaker is Dr. David Lowe, which is a consultant immunologist and immunology clinical lead at the Royal Free London. His practice is focused on immune deficiency, particularly in antibody deficiency and CGD, who will present or restore the microbiome or continue antibiotic prophylaxis. The floor is yours, David.
Great. Thanks so much, Sylvia. Can you hear me okay?
Perfectly. Yeah.
Great. So, yeah, thank you very much for asking me to speak and to come and talk about the microbiome to immunologists, which may be a challenge, but let's see how we do. Right. So I thought, given that most of the audience, I assume, will be immunologists, we ought to start with a little bit of the language that we use in microbiome research. And this isn't, of course, exhaustive, but hopefully this gets you through this presentation. So the first thing to consider are the taxa that we talk about in when we discuss microbiome work. Sometimes we talk about OTUs, operational taxonomic units, or ASVs, amplicon sequence variants. We won't get into the bioinformatics too much. There's different ways of dealing with sequence error. But essentially, this is the unit of microbiome. So this is after you sequence and then gone through the bioinformatics. Computer says we've got all of these reads which we think look like something, look like X, and we usually report that at the genus level. You can report it at species level, but there's more error, more uncertainty at species level. So we generally report this at genus level. And so essentially for each sample that you've processed, you end up with an output that is, you've got all of these different genera at these different proportions. Okay. And this brings us on to alpha diversity. So when we talk about alpha diversity in a microbiome, what we're really talking about is the richness and the evenness of the species in a particular sample. So if you look at the bar charts down at the bottom, if you look at those ones on the left, which would say IC, which means immunocompetent, and these are from sputum, these are respiratory samples, and what we can see here, that each column is one person. Each column is one person, and then each little colored bar within that column is the proportion of the different genera. So the bottom dark blue one is streptococci. The next slightly less dark blue one is Haemophilus, for example. And what you really want to see is that you've got lots, and we usually just would show the top 20. But you want to see that you've got lots of different things. There isn't one particular genus that's absolutely dominating, certainly not one pathogenic genus that's absolutely dominating everything. So you want to see a richness of different species and relatively even distribution. And you can see in those immunocompetent people down there, bottom left, that's broadly what you see. And you can compare that to the next set of of columns, which are these are now immunodeficient, antibody deficient patients. The first set with what we call abnormal airways, generally bronchiectasis, and then even in people with normal airways. And then you can see a very different pattern where for many of the patients, it is completely dominated by a single genus, right? So you've got, for example, 90+% of the reeds are Haemophilus. Okay, and so this is where you don't have diversity, you don't have richness, you don't have evenness of different genera, and that is low alpha diversity. And broadly speaking, low alpha diversity is bad. Okay. Beta diversity is really when we compare one population to another population, and we say, are they different? So in terms of the species or the genera that are there and the distribution of them. And then we think about functional pathways, and this is where it's a slightly more recent development, but where we try to be a bit smarter. Rather than just saying the names of the bugs that happen to be there, we should think more carefully about what their actual function is, because various different bacteria could do the same job. And actually, it's their job that's really important. So we can infer using computers what the function of those different species and genera that we've identified is, and therefore, we can analyze on that basis rather than just the names of what we found. And finally, we'll talk about the resistome, which is just a term for usually from metagenomics, where we find all of the resistance genes within a sample and we put all them together, and we call that the resistome. Right. So we'll start with some facts and then we get on to some conjecture. But the first fact is that the microbiome is abnormal in immune deficiency. That's probably not a big surprise. But here we're looking to those previous bar charts, which already showed that. I mean, already showed that alpha diversity was clearly much lower in the immune deficient patients with this dominance of pathogens in many people. Here we're looking at stool samples. The figures on the left are from some work we did. Figures on the right are from Celia Jorgensen and her group, but they both essentially show the same thing, that this is in CVID, that the CVID patients have lower alpha diversity than healthy controls. And interestingly, we divided patients according to whether or not they had diarrhea and found that further impacted the alpha diversity. Celia looked at whether they were infection only or whether they were complicated phenotype CVID and found that really had a relationship with the alpha diversity. So the lowest alpha diversity was seen in the most complex patients and the patients with the most inflammatory complications. And that's something that I'll come back to in a minute. She also found that IgA seemed to be an important component, an important predictor of lower alpha diversity. So if we think about why do our patients have a disrupted microbiome? And this is about the gut, but you could actually make a pretty similar figure for the respiratory tract. But of course, most of our microbiota is within the gut. And the top panel here shows the sort of healthy state where you've got a healthy microbiome, lots of different genera. They're all healthy, good bacteria. The good bacteria we keep getting sold, with Facebook adverts or random emails. So these are the nicely distributed, healthy bacteria staying where they should. So in the lumen of the gut. They're being kept there via various mechanisms, including IgA. So IgA, an important component of this. You've then got an intact gut barrier, so we haven't got bacteria sort of coming across the gut barrier. And then on the host side, when we think about the mucosa-associated immune tissues, you have a nice, quiet, tolerogenic response. You can see lots of Tregs and things there. Okay, and that's what you want. You want an immunologically quiet response to some good bacteria sitting, minding their own, not completely minding their own business, but sitting in the lumen. They will be manufacturing certain proteins like short-chain fatty acids, which are doing broadly good things for us. But that can all get disrupted. So if you look at the lower panel here, you've got an abnormal microbiome. So pathogenic species, dominance of abnormal bacteria, you lose that gut integrity. The bacteria themselves invade across the gut barrier and then set off really inflammatory immune responses, which have really distal consequences as well. So they don't just give you potentially local inflammation, but also distal inflammation as well. And you can see in that bottom figure, there's some joints, and there's a brain, and there's an eye. I'm not sure why there's an eye, but anyway, there are various other organs that can be affected by this pro-inflammatory immune response. So why do we get that situation? And I think the lower situation in our patients, and there's a whole load of reasons. Antibiotics we'll come back to, of course, but is a significant part of that. Antibiotics will disrupt your microbiome. Things like other chronic infections at the gut lumen, including chronic viral infections like norovirus, not having IgA, big component of the risk here. Contact with hospitals, which might expose you to more pathogenic bacteria, for example, and inflammatory gut disease, which we know a lot of our patients have, which will disrupt that gut barrier integrity. And then, of course, on the the other side, if you like, the mucosal side, you've got the immune deficiency, the dysregulation, and the immunoactive drugs that a lot of our patients end up on. Okay, so there's good reasons why the microbiome is abnormal in our immune deficient patients. The microbiome is also abnormal in a huge range of other conditions. So we know, and there's pretty good evidence, that it's very abnormal in cancer, it's very abnormal in most autoimmune disease, it's very abnormal in many luminal gut diseases, especially inflammatory bowel disease. But it's also implicated in a whole range of other disorders, including the response to chemotherapy and checkpoint inhibitors, lots of data on that in the oncology literature, asthma, atopy. And if you look at the figure there, what the theory is that as you develop your microbiota in early life, and that's of course impacted by your diet, by receipt of antibiotics, for example, as a young child, by your exposure to your environment, hopefully you develop a nice, healthy, diverse microbiome with high alpha diversity. If you don't, and so you end up in the top panel of the previous slide. If you don't, you end up in the bottom panel with this unhealthy microbiome, this pro-inflammatory immune response to that, which can then loss of tolerance and a lot of consequences downstream because of that, including allergy, for example. But it's also implicating cardiovascular disease, obesity, diabetes, dementia, behavioral disorders. There's data now on post-COVID-19 syndrome, AKI, osteoporosis. Now, some of this is, you can argue whether it's cause or effect, right? Sometimes people are sick for another reason, and therefore their microbiome gets disrupted, perhaps because they have a lot of antibiotics, perhaps because hospital exposure, etc. But there are good scientific reasons to suspect that a lot of the pathology is actually the other way around, that the abnormal microbiome contributes to the pathogenesis of a lot of these disorders. And as I say, lots of data. These are data here on stem cell transplant. And this is two separate studies, but they both show the same thing, that essentially, if you have a diverse or the good alpha diversity going into transplant, your survival is much better than if you have a low alpha diversity microbiome going into stem cell transplant. Okay, now again, that could be confounded. Maybe the people who had lower diversity had to have lots of antibiotics. Maybe they've been in hospital for ages because they were sicker people. So there are other things that will impact outcome. But it's interesting to note this and replicate it in two separate studies. Okay, so the microbiome is really abnormal in our patients. And one of the ways in which that happens is antibiotics. And antibiotics clearly affect your microbiome, and unfortunately tend to do that in a negative direction. There are some examples where you can use an antibiotic to get rid of an unhealthy population of bacteria and restore gut health, but broadly, antibiotics will negatively impact alpha diversity. So if you look at the figures down on the left-hand side, this is an infant study, and you can see that the number of courses of antibiotics in the last month clearly associates with a reduced, Shannon is one of the alpha diversity metrics, right? So reduced alpha diversity, and the more antibiotics you'd had, the poorer that alpha diversity was. And antibiotics clearly also lead to resistance, and we've heard a lot about that already. This study, I think, is fascinating and really important. From 2007, in this study, they gave healthy volunteers either 3 days of azithromycin or 7 days of clarithromycin or matched placebo. And if you look at the purple line, which is the azithromycin, so remember, this is just 3 days in otherwise healthy people. They then looked at macrolide resistance in that person's commensal bacteria. And you could see that it went from a baseline, about 20% of people had resistance, up to 90% immediately. Right? So 90% of healthy volunteers developed resistance within 3 days. And even 6 months later, you've still got over 40% of those people with resistance, right? So azithromycin is fantastic, and we've heard a lot of data on that as well, but it's also fantastic at causing resistance, right? And particularly effective antibiotic at driving resistance. Right. Now we get to the conjecture bit. So microbiome, there's a lot of relationship, and it makes sense from what I've shown you already between what's going on with the bugs in your gut and to some extent your respiratory tract and inflammation, including systemic inflammation. This is some work from Charlotte Cunningham-Rundle's group, where if you see the taxa bar charts on the left, these are all from serum, right? This is all from blood. But the bacteria you can see there are really gut bacteria. So these are predominantly gut bacteria that have got across that leaky gut barrier into the blood. And what they found is that the more bacterial DNA you had, well, if you divided the people into the CVID patients again into straightforward infection only versus people with complications, again, you saw more of this bacterial DNA in the blood in the people with the inflammatory type complications. We looked in CGD, and here this is all based on biopsies. This is actually mucosa-associated microbiome. And the top panels just show that we can pretty much separate out people with CGD colitis versus not. That perhaps doesn't surprise you. But the lower panels are, I think, more interesting. This is where we looked at people with systemic inflammation for any cause, any reason, versus not. And there we saw much better separation of the groups, and especially when we look at those functional pathways that I talked about at the beginning, rather than just the names of the bacteria that we're finding. So we're seeing the really different microbiome. This is beta diversity analysis, but this really different microbiome in the people who don't have inflammation versus people who do have inflammation. So there really seems to be this clear relationship borne out in immune deficiency and lots of other conditions that an unhealthy microbiota associates with systemic inflammation. If you look in the respiratory microbiome, similar sort of patterns. So these are some further data from those bar charts I showed you right at the beginning. Now, we measured all sorts of inflammatory cytokines in those healthy people and the antibody deficient people. It won't surprise you to know that all of the inflammatory cytokines in the sputum and in the serum were much higher in the immune deficient patients. And so were things like matrix metalloproteinases. These are the left-hand graphs here. Things like elastase, right? All very high. But what was interesting, the alpha diversity was much lower in the immune deficient patients. Again, that's not a surprise by now. But what was interesting is that the alpha diversity correlated negatively with the MMP9 and with the elastase. I haven't put that up here. So in other words, the more inflammation you had, the lower your alpha diversity. So again, this clear relationship between abnormal microbiome and significant inflammation in the airways. Interestingly, also that microbiome correlated negatively with the IgG level in the sputum. So putting a lot of IgG into the system didn't seem to make much of a difference. So interesting. We looked, by the way, at elastase in people on different forms of prophylaxis, and there was no difference between them. But this is not a randomized controlled trial. Okay, so just then to finish on resistance. Now, unfortunately, we see a lot of resistance in our patients on prophylaxis or not on prophylaxis. So for this study, we just took sputum samples. We took every colony on the plates, whether they looked pathogenic or not, multi-tophed them, and then took everything that was there in at least 2% of samples across our cohort. We then went on and did an antibiogram.
Da un sacco di lavori di altri.
Metagenomics.
Esatto.
And what we can see on the top graphs there is this huge rates of azithromycin resistance, even in the people on no prophylaxis, even on the people over 60%, even the people on non-macrolide prophylaxis, 80%, and then the people on macrolides, 90% resistance. The lower graph essentially shows a very similar thing. I'm not going to go into this in detail, apart from to say this is the resistome, and all of those little colored squares are resistance genes in these bacteria that we found, most of them associated with azithromycin resistance. And what we saw is that these are mainly commensal streps, but they're swapping them between each other. A lot of these resistance genes are on plasmids and other mobile genetic elements, and they're swapping them between each other. And when we look at the pathogens, here, Haemophilus and Pseudomonas, we're finding these resistant organisms not just swapping between organisms within a person, but actually swapping between people as well. So we're finding pairs within our cohort. They all come for infusions together. You see, they come for their intravenous infusions and they have a chat. And as they sit and have a chat, they are passing their bacteria to each other. So we saw that for Haemophilus and for Pseudomonas. So we think the microbiome is bad in our patients. We think that associates with inflammation. We'd like to improve that in some way. How can you do it? Well, there's various options. The one way in which we know you can definitely make a big difference to the gut microbiome is fecal transplant, okay, FMT. That's got issues, including issues of safety, especially for immune deficient patients. So there are lots of people now coming up with synthetic equivalents where they're just trying to put lots of different healthy bacterial populations together to mimic what would be in an FMT. There's probiotics, which we know about, which are essentially nutrients for the good bacteria. There's prebiotics, which are the good bacteria themselves. There's symbiotics, which is probiotics and prebiotics put together. There's postbiotics, which is saying, well, actually, the important thing is what the bacteria make. It's those sort of short-chain fatty acids that they make. So let's just give them instead of the bacteria. Then you can give it exclusive enteral nutrition, where you just give the nutrients, and that we know that has a big impact on microbiome, especially in inflammatory bowel disease. Or you can just alter your diet. Or there's various ways in which you can try, and rather than restoring the good bacteria, you can try and kill the bad bacteria, if you like, with things like bacteriophages. Has it worked? Well, yes, it works for C. diff. Yes, it works for inflammatory bowel disease, FMT, and exclusive enteral diet. And there's some reasonable evidence now that it helps responses to certain types of chemotherapy and checkpoint inhibitors if you improve your microbiota ahead of time. Starting to get some human evidence for fatty liver disease, for diabetes, and various other inclusive behavioral disorders, but nobody has come along yet and said, I've restored that microbiome and therefore I've cured someone's rheumatoid arthritis or lupus or whatever it is. So I think, although there's lots of good scientific data to link abnormal microbiota with a lot of conditions, if we're honest, outside of conditions which directly affect the gut lumen itself, we haven't really seen good evidence that changing the microbiota once those diseases are established can reverse them. So what can we do? And this is my last slide, is just, I think these are sort of realistic research questions. Can we minimize our antibiotic use, especially for breakthroughs? So can we use some sort of biomarker to guide antibiotics in our patients, point of care tests, to, point of care PCRs? Is it a virus rather than a bacterium? Point of care CRP, the elastase level, I have time to go through it, but those lower graphs are also in that same study, show that the elastase level seems to vary as the microbiome varies in sputum. So that could be a good indicator that the pathogenic bacteria are starting to expand. Is azithromycin the best prophylaxis? It's got a lot of advantages, but it's also very good at driving resistance. Is something else just as good without the same level of resistance? I think that's a study that is open, doxycycline, cotrimoxyl, which Alex mentioned. Maybe, I don't think modifying the microbiome is going to cure CVID, but maybe there's a role for, after courses of antibiotics, we should be restoring a healthy microbiota And there, that might be something where, you know, using probiotics, for example, after a course of antibiotics could have a role. And there is certainly some enough interesting data to say that actually properly restoring your microbiota, for example, with FMT before you go into transplant could be a really beneficial thing to do. And actually, there's a trial just started on that for AML. So people having a transplant for AML by giving them FMT prior to the transplant. Right, that's it from me. Thank you very much. These are all the people who did all the work and paid for it. So thank you very much.
Thank you very much, David. So just to summarize the previous talks, the issue of antibiotic prophylaxis in inborn errors of immunity is a subject of ongoing debate due to the lack of clear guidelines and the limited data available, so the low level of evidence. There are clinical trials that demonstrated efficacy, such as CVID, the work of Isabella Quinti, or CGD, as Alexandra showed, and also the clear benefit in SCID or STAT3 or STAT1, as Alexandra has told us. But there are also drawbacks of antibiotic use, which are clear microbial resistance, and Monica has shown how is the surveillance in Europe, and also the negatively impact alpha diversity, as and the wonderful data that David has shown to us. Isabella, would you like to do any comment on the, and then we start with the questions?
Very brief comment is the same I said at the beginning. So this is a very hot topic, and we need more effort, because I think we are facing different problems. We have facing infection in our patient, we are facing antibiotic use, we are facing antibiotic prophylaxis, we are using changing microbiota, and we are facing the question how to restore a correct microbiota, and also to switch on the inflammation consequently. And so the problem antibiotic resistance is a general goal in the general population and also in our patient. Because if we lose the possibility to treat also acute infection, not only by prophylaxis, but also as antibiotic as a treatment, we will face a difficult situation in the future. So we have a big responsibility. No one is not responsible. Everybody taking care of this patient in some way contribute to the problem, and we do not have the response, as I said at the beginning, and we do not have the response also at the end of this webinar. And I strongly suggest ESID and other immunological society to address this point deeply, because we cannot leave our future generation and future colleagues with such a bad scenario. And so we have a big responsibility. As I said, we have no conclusion. We have some question. Sylvia, you want to read something, but I think we are late. Maybe we can ask ESID to provide us the name of the email address of those people who send the question, or you want to start with some few questions? We have few minutes. Sylvia, what do you prefer?
There are some questions that maybe 3 questions. For example, the first one is for you, Isabella, and also maybe Alexandra. Did you do baseline ECG electrocardiogram in all patients before starting azithromycin?
But yes, we have ECG. The cardiology is part of our network of people working in the care of our patient. Of course we do, but we never see in our study, remember it was a 3 years study, we never had ECG alteration. No, so, or in general, cardiovascular adverse event. But okay, of course, ECG is part of the normal routine in this patient.
Okay, thank you very much. There is a question for Monica regarding antibiotic resistance used in humans, animals, or plants? Which is most important?
Oh, obviously, we are deal with the human health. So the use, we have seen that the misuse and the overuse of antibiotics in humans deal with a lot of deaths caused by AMR. All these sectors, human, animal, and plants, are interconnected, and in fact, due to this interconnection, to fight AMR since 2015, a One Health approach is adopted, but the wrong use and the use not appropriate of antibiotics in humans affects human health and causes deaths, but also affect economic aspects. So AMR in humans, it's really important, but we cannot, we have to take in consideration that AMR also in animal can contribute to increase the AMR level also in human, because antibiotic-resistant pathogen in animals can jump in human, exchanging mobile genetic element containing antibiotic-resistant determinants, and so AMR can increase and can worsen the situation, but mainly the increase of AMR can cause death in humans. So we have to curb AMR in human for the human health, and we have to save also the animal health, and we have to combat AMR through a One Health approach.
Thank you very much, Monica. And one question just for David. What is the gut microbiome like in patients with selective IgA deficiency with absent IgA, but where they are usually clinical well compared with controls? Can you?
Yeah, no, there is some evidence on this. So it is abnormal. They have dysbiosis in IgA deficiency. It's not as abnormal. And there is a theory that there's lots of compensatory IgM that is secreted, and that might help. But no, there is an element of dysbiosis, and of course that may be one of the explanations for more autoimmunity in IgA deficiency, and people with true selective IgA deficiency.
Okay. Thank you very much. There are many interesting questions, but I think we have run out of time. So
I tried to answer some in the text thing too.
Oh yeah.
I'm trying to put in a couple, but Klaus asked one that has more of an answer, but yeah.
Silvia,
but we can always email.
Silvia, may I ask Alexandra if the sentence I said at the beginning, that in USA, the antibiotic prophylaxis is more widely used than in Europe. Do you have the same impression? Do you have the same data? Or is it just a curiosity and has no scientific basis for this sentence?
It was interesting when you said that. I mean, I noticed that recently with the JAK inhibitors, the prophylaxis being different there with antivirals, though. The antibiotic prophylaxis, I don't know. I don't know if anyone has systematically looked at that, comparing the two regions. I think that would be a great study to see across. I think just in my discussions with some people, I think you all probably do more azithromycin by itself, and we do probably I'm not talking about CGD, for other types of defects, either antibody defects or hyper IgE syndrome or whatever. Like, I think you all might use more azithromycin, and we might use more combination of either trimethoprim sulfa with azithro or combinations. But I'm not sure, I mean, the ones I really know is that we use more interferon gamma, right? Because it's a little bit cost prohibitive sometimes. And the acyclovir, I think, is different.
So
So
in
I think
summary,
it's really interesting. We probably are too lax though with our antibiotics over here. But you know, in the past, there's some European countries that had worse antibiotic resistance than the US. Because it's harder for us to get antibiotics. Like we don't have them over the counter in pharmacies like they have in certain, not all, but in certain European countries.
So I think that we need to discuss more, and we need the exact figure on how many patients,
Yeah.
which PID, which inborn error of immunity, which age. What we don't have data. So we
Right,
are
I agree.
So Silvia, please conclude it.
Absolutely. So a huge thank to all our distinguished speakers today. And of course, also to extend these thanks to the ESID Working Party for organizing these webinars, and especially to Seaborn. And thank you very much, Isabella. It was a pleasure to be here with you today. And thank you very much for your attention.